Good morning, everyone, and thank you for attending our May P&T Committee meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For P&T committee members, please reserve your question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaiepharmacy@utah.gov. Attendees that are not a member of the P&T committee, please enter your contact information in the Google Meet chat or send an email to medicaiepharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And with that, I will leave it to Dr. Siegfried.
Good morning. I'd like to call the Pharmacy and Therapeutics Committee meeting on Thursday, May 21st, 2026 to order. And note that we have a quorum. And second, I'd like to see if everyone has reviewed the minutes from Thursday, February 19th, 2026, and whether there were any amendments or changes that needed to be made. I myself just noted that my last name was misspelled on numbers 2 and 7B and 7C.
I also noticed that the year of the minutes is not correct.
Oh, yes. Thank you.
Motion to change that too.
Were there any other amendments that needed to be made to these minutes? Is there a motion to approve these minutes?
Motion to, I want to make a motion to approve the minute as amended.
Second? I'll go ahead and second the motion. All in favor?
Aye.
Okay. Any opposed or abstentions? Hearing none, the minutes from February have been approved. The next item on our agenda is housekeeping, and I'll let you handle that.
Thank you. We have one new committee members, Dr. Courtney Hardy. I see that Dr. Hardy is on the call. Would you like to introduce yourself to the committee?
Sure. I'm Courtney Hardy. I go by Court, and I am honored to be a member of your committee.
Thank you.
Thank you and welcome. Next, we will hear from Luis with the DUR board update.
Good morning, everyone. So the DUR board met in March to review the topic GLP-1 receptor agonist for the treatment of obesity, long-term benefits and discontinuation after ongoing treatment. And we also, in March, we reviewed prior authorizations for Kinsula and Pompe disease. And then in April, we met to discuss a second topic on GLPs, which was understanding the economic value of FDA-approved GLP-1 receptor agonists for weight loss maintenance. And we also reviewed prior authorizations for Kinsula, Gambri, IBAT inhibitors, and iDose TR. And then last week in May, we met to discuss two new prior authorization forms for Pivia, and then also Zolgensma and Idvisma. Also in April, we added 3 new board members: a physician, Dr. Jason Ramirez, pharmacist, Dr. Stephanie Burns, and consumer representative, Tony Patterson. And now we just need 1 more pharmacist to have a complete 12 board membership. Thank you so much.
Thank you. And now we will turn to Dr. Gonzalez for our review of opioid overdose reversal agents from the DRRC.
Hello, good morning. Let me pull those slides up for you here. Okay, can you see those on your end? I'm trying to be nice on my screen here. Okay. So today we're talking about the opioid overdose reversal agents. See if I could get this slide to progress. Okay. In 2023, there were approximately 80,000 opioid-associated overdose deaths that occurred in the U.S. The incident rate was highest for deaths associated with non-methadone synthetic opioids such as fentanyl and its analogs compared to heroin or prescription-type opioids. Fentanyl is uniquely pervasive. Over the last decade, it has been involved in more opioid-related deaths than any other opioid. Recently, 90% of opioid-associated deaths involve synthetic opioids, primarily illicitly made fentanyls. Another feature of the current opioid crisis is that polysubstance overdoses predominate fatal cases versus single substance use. Common co-substances include alcohol, stimulants, benzodiazepines, and illicitly made fentanyls as additives to less potent opioids or laced into other classes of street drugs. It should be considered that some overdose cases may not have intended to use an opioid, yet exposure may occur through adulterated products. At the state level, there were 416 opioid-associated deaths in 2024. Illicitly made fentanyls were present in 60% of these cases. Respiratory depression is the cardinal symptom of opioid overdose, stemming from the agonistic effect at opioid receptors, primarily the mu-opioid receptor. Some opioids have unique sequelae that can complicate an overdose. For instance, fentanyl has noradrenergic effects that are thought to contribute to its induction of wooden chest syndrome, which is characterized by chest and diaphragm muscles stiffening, laryngospasm, and vocal cord closure. This syndrome is unique to fentanyl and its derivatives. Fentanyl may also directly impact cardiac function. Providing opioid antagonist rescue therapy to at-risk persons has become widely implemented to prevent death from opioid overdose. Opioid antagonists approved for emergency reversal of opioid overdose include naloxone and nalmefene. These agents antagonize the effects of the classical opioid receptors. However, they may not reliably reverse fentanyl-induced wooden chest syndrome. Ready-to-use naloxone and nalmefene formulations have been developed to improve usability for non-medical responders of opioid overdose, to increase access to overdose rescue therapy in the community setting, and as for some formulations, to provide higher doses and exposure to the opioid antagonist in response to high-potency overdoses. Ready-to-use products include nasal and injectable devices that do not require complex preparation steps prior to their administration. Nonetheless, layperson use of these products is not a substitute for emergency medical services, abbreviated EMS, as a person with overdose may require additional doses of an opioid antagonist or other antidotes for co-substances, along with cardiopulmonary resuscitation, or CPR. Notably, opioid antagonists cannot reverse cardiac arrest, in which case CPR would be required. This table shows the available naloxone and nalmefene formulations grouped according to their mode of administration and then by marketing status as available by prescription only, abbreviated RX, or as over-the-counter products, abbreviated as OTCs. All the listed products, except for the generic injectable solutions at the bottom of the table, are ready-to-use products. The first ready-to-use device was approved in 2015, as Narcan RX, delivering 4 milligrams of naloxone per dose. In more recent years, since 2021, additional doses have been brought to the market. Ready-to-use RX nasal sprays include the nalmefene-containing device OPV and naloxone-containing devices Cloxato, Rezenapy, and Rextovy. The prescription-only version of Narcan and its generic may be currently phasing out, as OTC versions of those are now available. Ready-to-use injectable formulations include the nalmefene-containing device Zerny and a naloxone-containing device Zimi. These products are to be used intramuscularly or subcutaneously as a secondary option. Non-ready-to-use generic injectable solutions are also available for naloxone and nalmefene that come as either pre-filled syringes and or in glass vials. Most pre-filled syringes require assembly steps and do not come pre-packaged with the needle. These non-ready-to-use products are used in a healthcare setting or may be used by a professional first responder or well-trained lay person in the community setting. Especially before the availability of the ready-to-use devices, generic naloxone injectable solution was incorporated into take-home kits with durable medical equipment such as a mucosal atomizer device to facilitate improvised intranasal administration. Each ready-to-use device delivers a single fixed dose of the opioid antagonist. A new unit dose device is needed for additional administration of a subsequent dose. One package or one carton of these products contains 2 unit dose devices. Because each formulation has unique pharmacokinetics or PK, they should not be compared solely on a milligram to milligram basis to make inferences about the comparative plasma drug exposure per dose. The dose for nasal spray devices is a single spray into the nostril, or for the injectable devices is a single intramuscular injection administered immediately upon the recognition of or suspicion of opioid overdose. Additional doses with a new unit dose device can be given if the patient does not respond to a dose or if they relapse into respiratory depression after an initial response to a dose. Repeat doses may be given up to every 2 minutes as needed. Repeat intranasal doses should also alternate nostrils with each sequential dose. Comparisons on this slide are based on reviewing PK information from package inserts, which comes from studies generally in healthy volunteers unexposed to opioids. An intramuscular dose of Zimi delivering 5 milligrams of naloxone yields higher naloxone exposure compared to the 2 milligram traditional high-end intramuscular dose with generic naloxone solution. Of the newer naloxone devices, only Cloxato's package insert included a PK comparison study to another nasal product. Yet sources do not detail the precise nasal product used aside from the dose of 4 milligrams. It's presumed that the comparator was either Narcan or its generic. Naloxone plasma concentration curves illustrated a higher peak concentration and higher plasma concentrations at 5 and 10 minutes post-dose with Cloxato 4 milligrams and 8 milligram nasal sprays versus the comparator 4 milligram naloxone nasal spray device. The following descriptions are based on indirectly comparing PK data from different studies, which is potentially unreliable. Each of these indirect comparisons are with respect to a 2 milligram intramuscular dose of naloxone, which is the traditional high-end dose for the generic injectable product. Compared to this traditional dose, Cloxato, Rezenapy, Kloxxado and Rosenapine nasal spray devices seem like they yield higher naloxone plasma concentrations. Rextovy nasal spray seems like it yields a comparable or slightly lower naloxone exposure, and Narcan RX may yield comparable or slightly higher naloxone exposure. Nalmefene has a half-life between 7 and 11 hours, which is comparatively longer than naloxone's half-life of up to 3 hours. A longer half-life might translate to a reduced need for additional doses of the rescue agent, particularly when the overdose is due to an opioid and dose that will outlast naloxone. However, a long duration of action could also pose a risk for long-lasting opioid withdrawal in opioid-dependent persons. Compared to a 1 milligram IM dose of generic nalmefene, the Zernite 1.5 IM dose and the OPV 2.7 milligram intranasal doses both yield a higher nalmefene Cmax and time-dependent exposures. It is important to consider the various lay bystanders most likely to first encounter and respond to an overdose, and their abilities and familiarity with products and procedures. Some bystanders may be very familiar and are trained in overdose response, whereas others may have no or minimal training and low confidence in their ability to respond. The usability features of products can influence the practicality of having the antidote readily administratable. Environmental factors may also influence the ease of product administration. For instance, products that require high levels of dexterity or visual acuity, such as generic injectable solutions, may hinder prompt administration in very cold or dimly lit settings. Whether or not the bystander will call 911 is also a concern that may influence a provider's preference for a high exposure or longer acting product. Intended persons to receive the rescue agent may also have different product preferences. There may be certain products some people are unwilling to carry due to fear of inducing severe opioid withdrawal. Product storage requirements should be considered relative to the location and environmental exposures of the patient. The patient's unique characteristics, needs, circumstances, and opioid exposure risk should be considered when choosing a product for the individual and their potential rescuer. Products yielding higher opioid antagonist exposures might be preferable for people residing where an ambulance cannot promptly get to them and who are far from an ER, since the person is at that point reliant on the few doses they carry. U.S. guidelines regarding layperson first aid response for opioid overdose are authored by the American Heart Association, or AHA. Prior to 2025, their guidelines recommended naloxone for opioid overdose, but recent updates recommend an opioid antagonist in general, without preference specified for one formulation over another. While no preference is given for a particular opioid antagonist formulation, authors do mention that the clinical evidence base is more robust for naloxone in general compared to nalmefene. In a 2023 guideline by the Naloxone Guidance Development Group of Canada, authors recommended offering naloxone as an intranasal device due to its ease of use, along with the option of a titratable intramuscular formulation for skilled responders. This recommendation was developed to acknowledge the wide range of usability factors across formulations and the variability in skill sets among overdose responders. Similarly, other guidelines published prior to 2025 included naloxone for risk mitigation strategies. In the 2022 opioid prescribing guidance by the CDC, naloxone was recommended to be offered to patients and their household members when prescribing 50 morphine milligram equivalents or more per day, or to patients prescribed opioids with other overdose risk factors. In 2020, the American Society of Addiction Medicine recommended providing naloxone to patients being treated for or with a history of opioid use disorder. There are limited direct comparative studies for the clinical effectiveness of the reviewed opioid antagonist products. Only 3 small studies were identified that directly compared 2 or more ready-to-use formulations. Each of these studies compared a newer generation device to the mainstay naloxone intranasal device as Narcan or similar generic. No comparative studies were found for Kloxxado, Rosenapine, or Rextovy. The methodology of the identified studies involved simulation of opioid overdose effects by exposing participants to opioid-induced respiratory depression, abbreviated OIRD, using fentanyl or remifentanil in a controlled and highly monitored manner. Study inclusion numbers range from 21 to about 50 participants, primarily non-opioid dependent and generally healthy adult volunteers. These studies were randomized crossover studies with participants randomized to the sequence of experimental agents. Ventilation minute volume, abbreviated MV, was continuously monitored during the studies and served as the main measure to determine respiratory recovery upon opioid antagonist administration. Compared to naloxone 4 milligram nasal spray, Narcan, the naloxone 5 milligram intramuscular device, Zimi, demonstrated faster respiratory recovery in patients with fentanyl-induced respiratory depression. Minute volume improvements favoring Zimi were apparent at early time points. For example, the proportions of patients with 100% MV recovery at 2 and 4 minutes post opioid antagonist dose were 44% and 100% respectively for Zimi treated patients, whereas much fewer Narcan treated patients, 6% and 63% respectively, achieved 100% recovery at these early time points. On average, significantly fewer Zimi doses were required to achieve a return to baseline ventilation versus that required with Narcan. Compared to the naloxone 4 milligram nasal spray, Narcan or similar device, the nalmefene 1.5 milligram IM device, Zernai, and the nalmefene 2.7 milligram nasal spray, Opvi, both demonstrated faster respiratory recovery upon exposure to opioid-induced respiratory depression. Minute volume improvements favoring these nalmefene devices were apparent at 5 minutes post-dose and onward to at least 15 or 30 minutes, depending on the study. Based on the time curves for the mean change in minute volume, Opvi nasal spray achieved about 95% recovery by 5 minutes post-dose, while nasal naloxone 4 milligrams demonstrated a more gradual recovery, taking 10 to 20 minutes to reach near 95% recovery. A similar trend was seen for Zernai versus nasal naloxone based on the time course graph. It, however, remains unclear if these differences, which are on the order of minutes, that were observed in these simulation studies, will translate to meaningful differences in the real-world community setting, where additional variables may contribute to whether an overdose is reversible, such as the time to administration, condition of the patient, CPR skills of the respondent, and potentially contributing co-substances. Some experts consider the time to administration of the rescue therapy relative to the time point of opioid intake to be among the most impactful determinants of synthetic opioid reversibility, as respiratory or cardiac failure can occur within a matter of minutes of synthetic opioid intake. Increasing the dose and exposure to naloxone at a delayed time point will not necessarily overcome this time to administration factor. Labeled warnings for ready-to-use naloxone and nalmefene prescription products highlight that although an individual may respond positively to an initial dose, it is possible that relapse of overdose symptoms may arise, necessitating additional doses of the reversal agent. Thus, EMS should be contacted immediately after administering the first opioid antagonist dose, and the patient should be kept under continued surveillance until EMS arrives. Another key safety warning is regarding the potential for precipitating opioid withdrawal in those with opioid physical dependence. Some people may be vulnerable to life-threatening cardiac abnormalities precipitated during abrupt opioid withdrawal. Moreover, the distress from opioid withdrawal that occurs in a pre-hospital setting where symptoms are unmanaged by healthcare professionals could trigger the patient to try overriding the opioid antagonist with additional opioid intake, which could potentially result in death. The experience of non-medically managed opioid withdrawal could also trigger avoidance toward future use and carriage of an opioid antagonist. Nalmefene ready-to-use products are uniquely labeled with a warning regarding secondary overdose risk related to attempts to overcome opioid withdrawal induced by the opioid antagonist. So regarding pharmacy utilization data, in 2025, between 4,600 and 4,700 fee-for-service beneficiaries had at least one pharmacy claim for a naloxone-containing rescue device. Recent utilization has predominantly been for nasal spray products in general, and particularly for nasal spray devices delivering 4 milligrams of naloxone per dose. OTC nasal sprays account for the vast majority of claims, about 5,700 claims in 2025. Some patients had claims for prescription-only devices. There were 67 patients who filled Cloxato 8 milligrams and 59 who filled generic RX naloxone 4 milligram nasal spray in 2025. Injectable generic naloxone solutions appear sparsely filled compared to the nasal sprays, with 96 claims in total for 2025. No claims were identified for nalmefene containing products. Of note, prescription naloxone and nalmefene products are open access, unrestricted by placement or limits on the PDL. Notably, the Utah Medicaid covered OTC list includes naloxone nasal spray. So overdose with synthetic opioids entails a narrower window of opportunity for administering a reversal agent compared to less rapidly acting or less potent opioids like heroin. Other variables can affect the success of an overdose reversal beyond the opioid antagonist formulation and dose. For community-based opioid overdose response, AHA guidelines do not favor a particular opioid antagonist formulation over another. With a high prevalence of synthetic opioid-involved deaths and limited comparative studies, debate remains regarding the optimal opioid antagonist dose and formulation for administration by a lay responder. Nevertheless, the approach does not need to be a one-size-fits-all, but instead could or should be tailored to an individual's suspected exposures and risks, along with the skill sets and needs of their potential rescuer. Importantly, the choice of therapy should also involve the patient. If the drug class, opioid antagonist for opioid overdose reversal, is placed on the Utah Medicaid preferred drug list, we recommend offering at least one ready-to-use FDA-approved device as preferred, and at least one of the preferred options be for an intranasal naloxone 4 milligram device. For example, a product that yields similar naloxone exposure as to the Narcan RX device. We also recommend that patients have access to other formulations designated as non-preferred via prior authorization process without the requirement for a fail first step. Other PA could be developed where the emphasis is for the consideration of patient-specific circumstances that may reasonably favor a particular non-preferred product. All right, and that's all I have for you today. Thank you so much for your attention through that one.
Thank you, Dr. Gonzalez. Does anyone have any questions regarding the presentation?
I have a question. Valerie, do you know if any regulations or law that restrict payer to put these on formulary? Or to make like harder to access one product over the others? Or they require all of these products have to be available and accessible?
Yeah, we did not find any law that would restrict Medicaid from, managing those accordingly.
And I guess I have one more questions on those claims for the patients that you filed, 4,656 patients. Do you know if any of them, how many of them also have opioid claims?
As what? Opioids?
Have opioid claims when they also has the opioid reversal agent?
Oh, we didn't look at that. Yeah, that would be a separate question. Usually for these P&T reports, we just pulled the claims, but if there's other subsequent questions like that, that'd be an interesting like DUR question. Yeah.
Thank you.
I mean, for people, that are being prescribed 50 milligram morphine equivalents or more, nowadays you would expect that they would have one just for, just in case. And the state laws are written in a way to where prescribers are supposed to offer a prescription for naloxone if prescribing more than 50 milligram morphine equivalents or more than a 3-day supply of 50 milligram morphine equivalents per day. So yeah, there's a lot of encouragement to get these products to patients.
I just had a quick question. Should there be any preference given to a product that covers children, adolescents, and adults versus one labeled adults only in terms of one that would be a ready-to-use device as opposed to one that, would require, dosing based on milligram per kilogram status.
Let me see. I'm trying to remind myself. Pretty sure most of these, yeah, so the nalmefene products are approved for 12 years and older, whereas the naloxone products are approved for like any age. So yeah, that's a good idea. I mean, I'm not sure how many overdoses occur in like very young children. Usually, yeah, I haven't seen any data to that detail.
I'm thinking more accidental
Yeah.
occurrences as opposed to,
Mm-hmm.
but I think your recommendations do include a product that does include naloxone. So should cover that, full age group. Just, for individuals where there's, families where there's a potential, for accidental overdose in someone in a younger age group. Any further discussion or questions? Otherwise, I'm just going to read from your recommendation that propose recommending offering at least one ready-to-use FDA-approved device as preferred, and at least one preferred option be for an intranasal naloxone 4 milligram device. For example, a product that yields naloxone exposure similar to a Narcan prescription. And in addition, second recommendation that patients have access to other formulations designated as non-preferred via prior authorization without the requirement for a failed first step.
I can make a motion with that. Maybe I will add to the motions of what you suggest, Dr. Siegfried, to make sure that the select also a refer product that can cover the age for the pediatric patients as well.
Well, I think the intranasal naloxone 4 milligram device would cover children, adolescents, and adults, or the product that yields a naloxone exposure similar to the prescription Narcan. Since Dr. Gonzalez said that the Narcan covers all age groups as opposed to nalmefene.
Make a motion with the recommendations.
Okay. I'd like to make a motion that we approve the recommendation to offer at least one ready-to-use FDA-approved device as preferred, and at least one preferred option be for an intranasal naloxone 4 milligram device that yields a naloxone exposure similar to the prescription brand Narcan. All in favor?
Aye.
Aye. Any opposed or abstentions? Motion carries. And I will make a second motion that patients have access to other formulations designated as non-preferred via prior authorization without the requirement for a failed first step. All in favor?
Aye.
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 Any opposed? Or abstentions? That those motions are approved. Any other business today, Noon?
We don't have anything else.
Motion to approve, or I'm sorry, adjourn the meeting.
Second.
Oh, okay. And we will meet again on Thursday, September 17th. And the topic will be determined prior to that time. Thank you all for participating today, and we appreciate your work. Thank you.
Thank you.
Bye.